afternoon and welcome to the studio at Methodist DeBakey Heart and Vascular Center. My name is Stephen Little. I am a professor of medicine at Weill Cornell and at Houston Methodist. Join me today for this presentation, Dr. Mouaz Al-Mallah, also professor of medicine at Houston Methodist, both of us in the CV imaging department. I do have to note that Dr. Al-Mallah is the president-elect of the American Society of Nuclear Cardiology, and he'll be presenting to us the CT, Cmr, and PET implications of imaging for infectious endocarditis. By pure coincidence, I'm the president-elect of the American Society of Echo, and I'll be presenting the echo component. But we certainly did not set this up as any sort of debate, and we hope that we can present this in a balanced fashion. In terms of interaction, we have a few participants, internal participants of faculty and fellows on a Zoom call, but for many of the audience, you're looking online and following us online. If you'd like to interact with some questions, we have two ways to do that. You can join by the web. You go to pollev.com, enter DeBakey as a single word, and then pose your question. Alternatively, you can join by text. Text DeBakey to the number of 37607 and then send your message that way. And we should have some time, probably at the end of the presentations, to address some questions. Okay, so without further ado, I will start off with a discussion of the echocardiographic sort of approach to endocarditis. So I'll just point out the reference, ACC SAP 2022. It was a pleasure to work on this with our colleague, Dr. Mohammed Chamsi Pasha, former colleague Dr. Ramlawi, and myself have done and redone this chapter within XAP, and some of the content you'll see today then led to that chapter. So if you want to live this all over again, I refer you to the ACC chapter. So first question is, what is a vegetation? This is a native mitral valve with a large mobile mass on it. So this is an important image to start with because it shows some of the hallmarks of what endocarditis is by echo. So note that the mass is on the flow surface of the mitral valve, so the atrial side. That's typical. Note that there's a large bulky mass that's easily identified, also typical, smaller, more friable elements. But the motion of the mass can be described as oscillation. What does oscillation mean? It means that some element of the motion is independent of the cyclical motion of the valve itself. So there's valve motion, but then there's more than valve motion. So that's oscillation, and that's a very characteristic feature of most visible endocarditis lesions, oscillation. This is another valve, and you see it's much smaller, it's more subtle, but it also has that sort of flickering motion that is in excess of simply the cyclical motion of the valve. So that's a tricuspid valve vegetation in an IV drug user. So I mentioned this already. This is a graphic to really emphasize the nature of where the bacteria seeds is on the flow surfaces. So the atrial side of mitral and tricuspid valves, the ventricular side of aortic and pulmonic valves. So when you can identify the stock before any sort of significant destruction has occurred, typically it's on the flow surface. So what is the lesion that we refer to as an endocarditis mass? So basically it starts with endothelial disruption. Some form of tissue damage occurs, followed by inflammation. That then leads to this cascade of fibrin and platelet deposition, increased bacterial colonization. That's sort of step one of the vegetation. And then it cycles back with more fibrin, more platelet, more deposition, more bacteria, and we have the growth of the vegetation over time. After some time, depending on the nature of the organism, you then have consequences. Those can be break-offs, including thrombotic emboli and septic emboli, or local tissue destruction often manifests as perforation, abscess, or if it's a prosthetic valve, dehiscence. And this is sort of typical H&E stain of what a vegetation would look like. You see the fibrin and the platelets, those are the pink portions, mixed inflammatory cells in blue, and then particular organism staining depending on the stain used. But that's a typical microscopic view of the vegetation. You don't have to read all of these just to know that there's a long list of organisms that are certainly associated with endocarditis. This list has changed over time as we have an older population, and a greater proportion of our population has indwelling intracardiac devices. That certainly leads to a different collection. We also have more and more patients who are in some fashion immunocompromised, whether through disease entities like diabetes or after solid organ transplantation. Typically, those organisms at the bottom of the list, the sort of the farm animal associated, the pet associated, are often diagnosed with difficulty, usually with the assistance of an infectious disease specialist. So this is an important slide to show you because this is a transthoracic echo, clearly an abnormal mitral valve. You see some diffuse thickening on the posterior leaflet, not particularly mobile. And you see a very discrete sort of hammer-like lesion on the distal portion of the anterior leaflet. If you look closely at this, I would say you do not easily demonstrate oscillation of this mass. It looks very rhythmic with the motion of the valve. So this is the exception to the rule, and this is fungus. So fungal endocarditis really doesn't like to follow any rules. And that's the important thing of any rule, is to acknowledge the exception to the rule. So non-fungal tends to be oscillating. Fungal can do anything it wants. This is a pacemaker in the right heart. You can see sort of a bilobed, very large mass. There's some on the lead, perhaps some attributable to the attachment to the tricuspid valve, but generally not. And I say not because when you do a lead extraction, usually that's very effective in cleaning out the visible mass entirely. So after lead exchange, no mass at all, and it was all attached to the lead. This is an important view of the pulmonic valve on the proximal PA. And there's a linear mass there. Now, is it a dissection? That would be odd in the PA, but he doesn't have sort of features. It's perhaps oscillating. It's hard to know exactly what that is, but when you look at the company it keeps, and by that I mean the function of the pulmonic valve, you can see gross, wide open PI. So now you have PI collection with a sort of a long linear mass with a little bit of clinical history of an IV drug user and Staph aureus bacteremia. Now you have pretty definitive endocarditis as a diagnosis. So to touch on briefly the notion of non-infectious endocarditis, this 4-chamber echo, if you look closely again at the mitral valve, you see some very small, kind of friable, looks almost like carpeting on the very tips of the valve. So quite unique in terms of what we would generally identify. It would almost be considered a Lamble's if it were on the aortic valve, but it's on the mitral valve. So this is an example of Liebman-Sachs endocarditis. This is a pathologic specimen. These flat, sort of a pale tan, all along the closure surface. So not a discrete singular location, but really quite diffuse, even on the chordae at times. So this is a whole class of non-infectious endocarditis. So the inflammatory mass lesion like this one, Liebman-Sachs, generally associated with SLE. Sterile vegetations are also referred to as merantic endocarditis, usually associated with advanced malignancies, particularly adenocarcinoma. And then finally, some cardiac tumors, particularly as a papillary fibroelastoma, can be quite difficult to differentiate from endocarditis. So what are the common complications of endocarditis? And this is where the echo lab often is a very important step. So let's go through that. This is a trans-esophageal echo, sort of a 3-chamber view looking at the mitral valve and the aortic valve. And if you look closely at the base of the posterior leaflet, you can see there's a little wiggling element. When we turn on the color Doppler, we see there's flow right there, and now MR by itself is not all that surprising sometimes, but if you look very closely, you see that the origin of the MR is not at the leaflet coaptation at all. This is where MR generally would occur, where anterior meets posterior leaflet in this 3-chamber view, but in fact we have a little wiggling motion, and we have what is a perforation at the base of the posterior leaflet. So that's a very telltale sign of endocarditis. It's exceedingly rare to have a spontaneous leaflet perforation without infection. And this is what an anterior leaflet, when it's excised, looks like, with a large central perforation. And this is that same patient, a fairly dramatic view from TE of the descending thoracic aorta with several pathologies all at once as sort of end stage complications of endocarditis. This is a dissection flap, a vegetation, and a penetrating ulcer. So this patient had a very, very poor prognosis. So we need to spend a minute or two on prosthetic valve manifestations of endocarditis. These can be particularly challenging. This is an old slide, this one. This used to be a representation of the breadth of prosthetic valve types. Now there's many, many more, including all of the transcatheter varieties that can now be implanted. So if we look at this particular case, again, a trans-esophageal echo, we tend to focus on the mitral valve, which has a little bit of diffuse thickening, but no specific wiggling vegetations that would meet that oscillation characteristic. We have the prosthetic leaflets moving here, and perhaps they don't look obviously abnormal. Often with prosthetic valves, one of the main challenges is the shadow that's created by the material of the prosthesis. But always remember not to look exclusively at the valves. And if you look just a little further up right here in the proximal ascending aorta, you see a different sort of wiggling gelatinous mass that's attached here. Remember, this is a TEE, and this was actually the site of the surgical aortotomy and the suture, and this ended up being a fungal vegetation attached to the aortotomy site just distal to the prosthesis. So another reason for this patient's poor health. This is a different patient. This is somebody 4 months after a surgical bioprosthetic AVR. The patient was unwell and had some elevated gradients, and you can clearly see a long linear mass distal to the leaflet. It's hard to tell in that particular view where the mass is attached, but we can see here at surgery, this was and ultimately through culture, this was a manifestation of nocardia endocarditis that actually attached at the base of the prosthetic leaflet. Very long linear mass. This was an interesting case. This is actually more than a decade ago, some of the first experience with 3D TEE, and you can even see some stitching in this view. This is focused on a post-op mitral valve case. This was sent from an outside hospital with concern about endocarditis. The patient was doing very well clinically, had really no concern, but a transthoracic echo had seen this linear mass wiggling in the left atrium. You see a surgical mitral ring, a long linear mass that's very unlike any sort of classic endocarditis lesion. And this is where history in the patient, and particularly the surgical history, is exceedingly important. And in fact, this was not vegetation at all. This was an untied suture from this particular surgical device called an attune ring, which is used to perform a undersized annuloplasty. So the suture had been untied, left wiggling in the left atrium, and trying to confuse echocardiographers ever since. Unsuccessfully. So that's an example of knowing the history of the patient and the intervention before coming up with the diagnosis of an atypical endocarditis. This is another case of a mechanical valve in the mitral position, and it demonstrates one of the hallmark features of mechanical endocarditis. Is you see the wiggling mass here on the right image and also on the left image. And note, it's rarely ever attached to the pyrolytic carbon surface of the actual leaflet, but much more often attached to the surgical ring. And that's this case manifests that some concern about actual obstruction by the mass in this case. Quite different is the scenario with a bioprosthetic valve. In a bioprosthetic valve, because it's biological leaflet tissue, you can very often get vegetations actually on the leaflet surface. So this is an example of that large, bulky mass attached right to the leaflets of this bioprosthetic mitral valve. In general, this is a very clear indication for a surgical replacement. In this particular patient, the surgical risk was very high, so the choice was to attempt at least parenteral antibiotics for several weeks. That appeared to be successful. After 6 weeks of antibiotics, the leaflets the bulk is gone, the gradients are not quite normal but much improved. But you do see that the leaflets aren't moving quite normally. There's still a bit of restriction and thickening to this leaflet, perhaps shown over here. But on the 3D imaging, a very interesting consequence is noted. These 3 paravalvular defects. So the endocarditis can manifest not just on the leaflets itself, but also anywhere in the surgical tissue around the valve. So these are 3 new paravalvular defects after relatively successful IV antibiotic therapy for bioprosthetic valve. So that's a very unusual course. Typically this would not have been this successful. This is another case of a mitral valve with a mechanical prosthesis. No paravalvular defect noted, no vegetation noted, very, very high flow. And this looks initially like things are okay. However, all of this space here, sort of between 12 and 2 o'clock, is not echo dropout. This is actually an enormous dehiscence because of recurrent culture-negative endocarditis. In this case, culture-negative because of the long history of parenteral antibiotic use after having a prior episode of endocarditis. So those two cases really to emphasize the importance of the echocardiographic review and understanding the cardiac anatomy. So the fibrous crux is another term for the fibrous skeleton of the heart, recognizing that all of that primum tissue where the aortic valve and the mitral valve and the tricuspid valve originate share common tissue. So any destruction, particularly can vary by organism, can go from one valve to another. So to give you an example of that, this is a 75-year-old gentleman who had a prior history of a biologic AVR 2 years ago, so not in any sort of immediate post-op concern, but fevers and chills, has this echo. On a little closer inspection using an X-plane for simultaneous 3D, you can see that there is a concern on the left image, a small identifiable mass that is not the prosthetic leaflet tissue. And you can even see it sort of popping into view on this X-plane view. So this was the concern, fevers, a mass, prosthetic valve, enough to say that this is likely endocarditis. In fact, when the Doppler was placed, the spectral Doppler, you can see had a very high gradient, over 4 meters, so it's also obstructive with severe prosthetic valve stenosis. So after 2 months of IV antibiotic and followed by a repeat, briefly there's a moment of good news. The mass seems to have resolved. The leaflet looks a little bit different. Is this really good news? Well, if you look closely again for the potential complication of a bioprosthetic valve infection, you see that there is a periprosthetic abscess evolving, shown here, sort of the very specific area of sort of lucency on echo. You see it in 2 orthogonal views. So that's a periaortic abscess. That is not going to clear with any form of IV antibiotic. Patient was sent for a redo surgery. But if you look back at the initial echo 2 months prior, you can see that it was really there already. So that's one of the things to be aware of. It's very common to have periprosthetic abscess, even small, and that has to be really what we're looking for in addition to any immediate valvular effect of infection. So this heart anatomy is all very close. Example, the pulmonic valve is nicely separated, but the other 3 are very close to each other, share a lot of common tissue from the left and right fibrous trigone into the septal tricuspid leaflets, the anterior mitral leaflet, and all 3 of the aortic cusps. If you look at the function of the intervalvular fibrosa, so this is a 3D view looking at the mitral valve, the anterior leaflet shown here, aortic valve to the left. If you look at this sort of pulsatile region here, you can see that the aortic outflow actually pulses through the anterior mitral leaflet and helps provide some closure. That's from above and from below. Again, looking up the LVOT. All of this just to emphasize, this is a very normal heart, probably the only normal I'll show you on this talk, but all of this anatomy is very close together. So particularly invasive organisms like Staph aureus will take advantage of this proximity. So we have to have a very high index of suspicion for associated lesions with endocarditis. And chances are, if you think it's 2 separate lesions, it probably isn't, or one led to the creation of the other. So this is a different example of an aortic root abscess. This is a sort of very clear thickening here. This one is fairly homogeneous in its sort of appearance, but often it is not so homogeneous. This is a later consequence. This is really a fatal event. This was an LV root abscess that actually tracked all the way into the LV and led to rupture of the LV. So that's sort of the worst case scenario. This is the more typical appearance of an aortic root abscess in the setting of prosthetic material, and you can see it's very non-homogeneous all the way through, so these little pockets of bacteria, but it's contained. It's not pulsatile, there's no flow in it. This will not be cleared by IV antibiotics. This is really the natural history, what can happen. So once that pocket opens up at one end, blood is allowed to get in. It clears out some of the bacteria, but now you have a pulsatile mass. So whenever you have pulsatility to one of these collections, that means it must be open at one end. Typically it's the ventricular side, so that's a pseudoaneurysm. And the color Doppler demonstrates flow into and out of, and you could also show this with an M mode. And then the sort of the complete natural history is that it ruptures in at the other end as well. So now it ruptures into the aorta. So now you have an opening at both ends that shouldn't be there, so that's a fistula. So this is an aortic root fistula or now a large paravalvular regurgitation spot. So the presence of the flow makes it a fistula. The physiologic effect generally is paravalvular leak. You can even have systolic flow around that, but typically that's less common. And this is just a surgical example of how you can have fistulas almost anywhere. This is from a probe is going down the aorta and actually comes out into the right atrium. So with particularly this is another case of Staph aureus, can really be quite aggressive and get connections almost anywhere. So in summary, endocarditis basically means inflammation of the endocardium. It usually involves the valves, but remember that other structures can be affected, the septa, the cords, any intracardiac device. The prototypic lesion is the vegetation, which is a mass of platelets, fibrin, microorganisms, and inflammatory cells. Echo is certainly the first line for the diagnosis and sometimes the last line if the therapy is clear from that point. But I'll close with this slide. And this is just sort of one of many different published algorithms, but this is an approach to the diagnosis of infectious endocarditis. It really starts with the clinical suspicion. You can apply the Duke criteria, which are readily available to all of us, looking at culture positive or even autopsy reports. But in general, we get to a definite infective endocarditis, possible or rejected. If it's a native valve that you're concerned about, it's very reasonable to start with an echo, transthoracic, if needed, a transesophageal, looking for embolic events and potentially a cardiac CT. Dr. Al-Mallah will really take us through the importance of the right side of this algorithm, which is prosthetic valves, starting with echo, considering PET CT and cardiac CT. So I'll stop there. I'll turn it over to my colleague, Dr. Al-Mallah, and we'll hear about the non-echo evaluation of endocarditis. Over to you, sir.
All right. Thanks, Steve, and this was wonderful review of the role of echo in endocarditis. Now I'm gonna try to put in my multi-modality hat and cover CT, CMR, and PET in endocarditis. So as Steve just showed us, echo is always the first tool that you're gonna use in assessment of these patients. However, there are many instances where you need to acquire additional information, and this is where these adjunctive modalities come into help. So here's cardiac CT, and you can see that there is a vegetation on one of the leaflets of the aortic valve, and this can be easily seen by echocardiography. But most often this is like sometimes an incidental finding on echocardiography. What we get on echocardiography are more often the complicated cases where there is a fistula or there is a abscess to assess by echocardiography. And here's yet another assessment of the vegetation by cardiac CT. So let me give you a rundown initially how accurate is CT for these assessments. Obviously you have to look at what is your comparator group or gold standard group. So if you're going to use TEE, CT is pretty good for assessment of endocarditis by 97%, specificity is 88%, and its negative predictive value is 88%, and this is mainly because small, highly mobile structures may not be well seen by CT. It depends on the temporal resolution of the system. If we're going to use operative findings, then sensitivity is pretty high, 96%. And if we're going to use vegetation size and mobility, there is good accuracy. However, again, it depends on the CT system you are using and how good the patient heart rate is and the other findings. So when do we use CT? It's like main advantages that we have higher spatial resolution, so it does allow us to look at the extra cardiac structures also and the immediate next adjacent structures. It will give you a full volumetric assessment for these patients, and sometimes it's preferred in patients with esophageal pathology, and we can look also at concomitant pathologies in these patients. You need less PPE because you're not as often so much adjacent to the patient. TEE obviously has the best temporal resolution in these patients, and flow assessment is by all means much better with TEE. And in terms of obviously patients with renal dysfunction and contrast allergies, these are much better served by TEE because you need contrast for these CTs to have good assessment of the aorta and its complication. So let me show you some of these cases that we see sometimes coming in for CT for confirmation of diagnosis or suspicion by TE. Here's, for example, you have some local complications of abscess and pseudoaneurysms that you can see. You can also look at patients who have a fistula, so this is how it looks when you have an LAO left atrial to aortic to left atrial fistula, as you see here. We can look also at pseudoaneurysms, as you see in here, and these are patients that could be pulsatile if we acquired it in retrospective gating. CT is always also thought of when we think of prosthetic valves, and what we try to look at is in CT try to look at these structures and come up with what are we looking at. So in CT there's something called Hounsfield unit, which each matter will have its own attenuation compared to water. So for example, air is -1000, and we try to look at these structures on these prosthetic valves and try to come up whether this is blood clot or so. So for example, one of the main sometimes assessment that we are asked to look at is whether this is a pannus or thrombus. Sometimes it's so much difficult to make such distinction, but sometimes we are able to make it with distinction if we're looking at the location, but also the Hounsfield unit. So if it's less than 90, it's usually a thrombus, and pannus is usually more than 145. Obviously, sometimes you can have the combination of both. Bioprosthetic valves, we can have a good assessment of these, and this is, for example, based on the Hounsfield unit, was called a thrombus. We can also look at the dehiscent valve. Again, we don't have the same temporal resolution as TE, but we have good visualization of these metallic valves and the surrounding structures, so we can provide adequate assessment of the valve and its pathology. And when looked at this in a series of patients with 75 patients who had both TEE and CTA, you can look, if you're looking for vegetation, obviously TE is your goal, because out of 75 patients with vegetations, 73 were picked up by TE, but only 54 were picked up by CT. And if you look, what CT missed are mainly the small ones, which are less than 1 centimeter. But if you're looking for intracardiac complications, this is where CT has a higher edge, where it picked up more perivalvular abscesses compared to TEE, and this is mainly because of the increased spatial resolution of CT. And this can also be looked for TAVR valves, which may be sometimes difficult to assess by transthoracic echo if you don't have good view of the valve or if there is shadowing. And this is, for example, one of my patients that had a TAVR valve, and she had a CT after, and everything looked fine, came in back with fever, and now you see the entire valve has full of thrombus-like material, but also she was having fever and positive blood cultures, and this patient actually arrested few hours after the CT, even before was considered for operation for this massive vegetation within the TAVR valve. We can also, by CT, look for extracardiac complications. So, for example, you can look for brain abscesses. Things that are immediately in the field of view that we often see are splenic infarcts, for example. Sometimes we get a glimpse at the renal if the tech went down a little bit, and we can see sometimes splenic infarcts, and also we can see mycotic aortic aneurysms that can be seen there. I would like also to mention that more often we are asked on these cases to do coronary assessment prior to surgery. So, for example, this patient didn't come to CT for assessment of the vegetation, but you can imagine everybody would be very concerned about engaging the coronaries when you have this vegetation on the leaflet, and we were asked to do coronary assessment for these patients, and this is where we potentially see these vegetations. Most most often these patients, especially if they have aortic insufficiency, they're febrile, they're tachycardic, and we are acquiring them despite having very high heart rate. And CT is still good, at least primarily to assess the main coronaries, but it depends again on the system. This is a meta-analysis that include different kind of 64 slice and higher kind of coronary CTs, and come up with a summary kind of assessment of sensitivity of 93 and specificity of 89%. But again, keep in mind, these are patients who are sick, tachycardic. I mean, sometimes we even try to acquire these cases despite having heart rates in the above 100. So because we're trying to avoid coronary angiography and to dislodge some of these vegetations on the aortic valve. So this is a quick summary of what CT can assess in these patients. So with endocarditis, cardiac MRI, we usually don't take these patients more often to the magnet when they are sick, but more often this could be an incidental finding or potentially assessment of potential complications of the endocarditis itself, like you see here, aortic insufficiency, for example, or mitral regurgitation in some of these patients that you may see in some of these cases. I'm going to try to focus on a new emerging tool, role of PET in these patients, because this is kind of dragging now, getting a lot of attention from different practices. And we can see that here, you can see that there is significant FDG uptake around the aortic valve, and we are pretty concerned that this is a patient who has significant endocarditis, and this is where PET comes in handy. But before that, I think I would like to emphasize that if you are considering cardiac PET for assessment of endocarditis, we need to prepare the patients very well, because what we do is that we are giving them fluorodeoxyglucose, and when we give them fluorodeoxyglucose, the myocardium likes that too. So we have to prepare the patient in a way that the myocardium doesn't take that fluorodeoxyglucose, and it will leave it for all these white blood cells and bacteria that are in the area of infection. So the way we do it is that we try to do low or no carbohydrate diet. We want them fasting more than 12 hours. If they are not on anticoagulation and there is no contraindication to heparin, we try to give them heparin, and then we inject fluorodeoxyglucose and image them after 1 hour. We're hoping that we have suppressed the myocardium well enough, so what we are seeing around the aortic valve is not related to myocardial uptake, but this is truly the infectious cells that are sitting around the area of interest we are looking at. And here's one case where you can see if we prepare the patient well, there is no uptake by the myocardium, which makes our job much easier to assess for endocarditis, while if there is significant cardiac uptake, it becomes more difficult really to be certain about the FDG uptake around the valve and make sure that this is vegetation. And here there are a few cases where it is different patterns that you can see in endocarditis, heterogeneous uptake, more focal uptake, and it is very much focused around the valve, but also in other areas. You can see here, for example, a patient who has not only the valve infected and multiple abscesses around the valve, but also the aortic root that is also affected. And here's yet another patient with an abscess, and you can see it's lighting up by FDG in this area. Now, this is another case from our lab where it was more of an equivocal echo. It was difficult to image this patient, and you can clearly see that we have by CTA and by FDG two suspicious lesions for an abscess, one and these were like confirmed by surgery, and this patient went same day for surgery and found the same kind of abscesses exactly as they were described here. You can also assess TAVR valves for that, so this is like for prosthetic valves. But the second message I want to leave you, and sometimes we get these requests from our colleagues, that this technique is not for native valves in a sense if you want to establish diagnosis. So this technique has low sensitivity for native valves for reasons that are not very clear. And here's one example from the literature where you see nothing on the aortic valve, but obviously on TE there is some vegetation on the aortic valve from this publication. So this has also a very important point to keep in mind. PET-CT does not have high sensitivity. So someone could argue that if I do it and if it is negative, it doesn't help me. If it is positive, then and it is well prepared, then it might be helpful. And it depends. You have to sort it out based on the clinical suspicion and what exactly you're looking for. And this is mostly for vegetation. If you have an abscess and complication of the aortic of endocarditis, then PET-CT is still going to work very well in these cases. So I'm going to have kind of mentioned what are the strengths of PET-CT, but I want to also highlight what would be the potential limitations. We have a false positive rate, which is mostly in one study was about 4 out of 26, mostly related to either surgical glue, but also related to fill preparation. There's slight abnormality on aortic grafts, so if there is bioglue, if the surgeon used a lot of it, sometimes you do get some uptake with that. I'll show you later on some examples. Sometimes if it's pure thrombosis, there is a small element of inflammation with thrombosis, which may be a little bit, could give you an could give you a similar picture. And then it's very early after surgery, still within the very early phase. Although there have been some reports that people were successful also immediately after surgery, not immediately, but within a month after surgery. And again, you have to use it here for its negative predictive value. So if it looks negative, you're pretty confident that there is nothing, but if it is positive, then it doesn't mean much. And here's one example of those low-grade inflammation after surgery that some of these patients have. So the biggest concern that we have when we do this is this infection or this is inflammation. So here I'm showing you one example which is very clear that there are focal heterogeneous uptake, and this is way more concerning for infection. And on the other hand, now I see more diffuse uptake, and this is actually from a publication in JACC Imaging, which the authors commented that this patient actually had allergy to the bioglue, and you can see that there is significant inflammation around the sternum, but also all through, and it is more diffuse. It's unlikely that infection is this bad and the patient is not in hemodynamic compromise. So we are always dealing with the spectrum, and it is more of a consult when we are looking at this. It's very helpful to look at multi-modality approaches. If there is a CT, it is very essential to kind of look also at the echocardiogram and try to correlate where we see the FTG uptake with how the images look. Even if the echo was not like identified as Steve earlier showed, sometimes FTG uptake make me more suspicious of subtle findings that were not seen initially. But more of a homogeneous low-grade uptake is inflammation. More of a very focal and heterogeneous uptake is more pointing toward infection, and this is how infection is, usually focal and heterogeneous. For example, this is one of our cases. The patient had recent surgery, and you can see here there was a concern by TEE whether there is an infection, and you can see low grade but very homogeneous, and you can see on the CT there is some additional bioglue that was seen there, and this is not concerning for infection. And you can see here on this non-contrast CT the bioglue. On another case, you can see also here, sorry, in the same case, the bioglue that you can see. Another case that we kind of struggle with, which is the effect of antibiotics therapy. Sometimes patients come to us, but they already had 2 or 3 weeks of antibiotics, where the inflammatory response or the white blood cell response to these infections have significantly decreased. And also you can see that some of these have much less uptake at that time, and that's why it's very important to keep that in mind when you are interpreting it. So you're not going to have the same intensity of FDG uptake when you are looking at these. So overall, for native valve endocarditis, we got a sensitivity of 31%, but we are very specific. For prosthetic valve endocarditis, this is where PET is extremely helpful, with an 86% sensitivity and 84% specificity. What PET-CT is going to be also very helpful is also to look for extra cardiac complications. So for example, you can see osteomyelitis, as you see here, or you can see discitis if it is in the field of view. And in one study, they found extra cardiac findings in about 60%, and about 15% of these were clinically relevant. We have always the lung in the view, so if we're concerned about tricuspid endocarditis, sometimes we could see septic emboli. A common question that always comes is, how good is PET compared to tagged white blood cell, which is more widely available. And here's one case from the literature where white blood cell did not pick it up, but FDG PET had actually significant focal heterogeneous uptake, as is shown here with the focality of it. And this is actually a patient who had endocarditis, but the main thing here is that it is more sensitive with FDG and more specific with white blood cell. FDG PET is not only for valvular endocarditis, we also look at pacing devices and their leads. So here, for example, a bad pocket infection that you see here, and you can see the FDG uptake up there, and you can see also the pacemaker pocket infection that was significant FDG uptake. And in a meta-analysis that recently looked at these, you can see that the sensitivity to detect these cardiac devices, endocarditis, was about 72% and specificity of 83%. And from a technical points for the fellows, we always tell them we want to look at the non-attenuation corrected images also, in addition to the attenuation corrected images, to help identify that. In this meta-analysis, again, to hammer the same point we discussed earlier, for prosthetic valves, we have 86% sensitivity, 84% specificity, but for native valves, the sensitivity is really low, 31%, but it is highly specific. So if we see it, then we are pretty sure that it is there. And lastly, our most latest front that we are working on is LVAD infections. As you know, these patients will have devices, and one of the common problems with these patients is that they have infections, and the infection can be at multiple sites. It can be at the drive line, at the pump, it can be at the inflow cannula if you have like a HeartMate 2, or it can be at the outflow cannula. And all of these we can assess by FDG PET imaging. So here's, for example, one patient where there is uptake in the entire drive line and very bad infection. This is another patient where you can see also an outflow cannula uptake, which is not as impressive as our recent case that we saw here, where you can see significant FDG uptake in the outflow and also closer to the insertion into the ascending aorta. And you can see also in this patient, for example, in the drive line, there is also at the entry point like very hot uptake, and this could be an abscess there, and these patients will require immediate attention and therapy. and you can also look at it in multiple sites. So it's very important to assess it, all 4 components of these patients with LVADs, to make sure that there are no uptake. And you can see the outcome of these patients is very bad if we detect infection. You can see that if there is no infection, they did well in this series, but if there is peripheral infection, they did intermediate, but central infection, especially if the device itself is infected, then these patients are actually going to do worse, and there is very high mortality associated with that. So how are we going to look at it from the guidelines standpoint? So the Europeans have been way more advanced in this, and this technique is actually more developed in Europe and more routinely used here. In the US, we're starting to use it more often, and especially in the LVAD and pacemaker population, in addition to complicated cases from prosthetic valves where patients actually, where CT or echocardiography could not provide a final answer. But this is a copy-paste from the recent document from Circulation, from the guidelines, where it says that it looks like the inclusion of abnormal FTG in the algorithm, it improves the Duke criteria and results in recategorization of about 76%. But the guidelines appropriately said that this tool must be used in centers with great experience with the technology. Many things could potentially go wrong, so you have to have a robust protocol and experienced readers. And because these techniques are prone to false positive, and we don't want to mislabel these patients. So they are primarily complementary diagnostic tools after you started with your echocardiography. And Steve have shown similar approach from the European guidelines, and clearly FTG is all over the place, primarily for possible or if it is a negative studies, negative prior other studies, but there is high suspicion for endocarditis. So the FTG PET is really making its way within these patients' population, hopefully providing help for many of these patients that we were not able to have definitive diagnosis before. With this, I'm going to stop, and we'll be happy to take any questions.
Thank you, Dr. Al-Mallah. That was, as usual, that was excellent. Quick question for you. Your early slides, you commented on the sensitivity and specificity of CT for the diagnosis of endocarditis. What was the reference standard?
So there were multiple. If you remember on that slide, let me maybe bring it back. So there were multiple reference standards used. So here CT, using TEE as a gold standard.
That's good enough right there. We can stop there. That's all I needed to hear.
That's all you needed to hear?
The President-elect of ASNIC, TEE standard.
Well, but I think if for the President-elect of American Society of Echo, I can show you this slide, where TE is obviously the tool given its temporal resolution for vegetation, but for extra cardiac complications, I think CT is still going to be your workhorse, and definitely combining it with PET CT, that's going to be very helpful for this. So, yep, I mean, I think after all, we have to put our modalities aside and keep the patient in the center and see what is going to make a difference in the management of these patients.
I just wanted to, since you've got that slide up, I wanted to comment one of the other great things about the CT in the decision around therapies. You know, if you see a large lesion and you know it's endocarditis, the manifestation of peripheral embolic event is often a push to go to surgery. So we've had multiple cases where you know, significant splenic infarct or other, exactly as you've shown here, was enough to convince the surgeon that it's time to go to therapy. So not just for the diagnosis, but also the next step management are often dependent upon these extracardiac manifestations.
And more often we are getting CT to assess the coronaries in a patient with endocarditis, and we identify further either local advanced, yeah, but TE has, and echocardiography with the advances, if you have good imaging windows, you are able to ascertain the diagnosis. But if you're contemplating surgery and there's a highly mobile lesion on the aortic valve, you want to make sure you want to assess the coronaries in the appropriate patient. You don't want to cath them, and this is where CT can add a lot of additional information.
We have some internal colleagues on Zoom. Just shout out to those on Zoom if anybody has a question. I think our technical folks here could maybe convey the question or unmute you, but we'll give that a second to see if that's possible. Hearing none, I'm looking at the Poll EV and DeBakey text tool, and I'm not seeing any questions there. So unless any questions come through, I think we'll go ahead and wrap it up. We'll thank you all for your time and attention. And please be sure to check out the entire DeBakey educational library for the breadth of all the cardiovascular presentations that are there for you. Thanks again. Thanks, Mouaz.
Thank you. Thanks, Steve.